Comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health DocTalk. Imagine the nerve fibers in the central nervous system that help pass messages from the brain to the rest of the body. They're covered by a protective sheath called myelin. When a person's immune system mistakes that material, or that myelin, for something foreign, it attacks it. The nerve fibers become exposed and at various levels damaged, which then disrupts the passage of signals sent by the brain. I've just described the basics of multiple sclerosis, an autoimmune disorder that affects about 2 million people in the U.S. MS is a lifelong condition that probably raises more questions than there are answers. But with the wisdom and insight of Dr. Tamar Harel, a board-certified neurologist and the director of Neuro-immunology and multiple sclerosis at MedStar Health, we're about to learn as much as we can about MS in this episode of MedStar Health DocTalk. I'm your host, Deborah Schindler. Thank you for sharing your expertise with us, Dr. Harel.
Thank you for having me on.
I gave a very rudimentary description of multiple sclerosis. Can you elaborate on what it is and how it impacts the central nervous system? What is the central nervous system?
Absolutely. So many people are concerned or confused about what is multiple sclerosis because it presents so differently in different individuals, and no one has exactly the same story or symptoms or course of disease. So multiple sclerosis is very similar to what you described, where I kind of think of it as our immune system is this army. It has its scouts and it has its soldiers, and its scouts scour the entire body looking for something that is foreign or an invader. And it then kind of gives off this call to the rest of the soldiers of the immune system to say, this is foreign, come attack this. Then it causes the immune system to attack that object that's identified as foreign. In the case of multiple sclerosis, it attacks our central nervous system. Our central nervous system is made up of our brain, some of the nerves in the eye, and also the spinal cord. And so when multiple sclerosis occurs and our immune system attacks those parts of the central nervous system, you can have damage to the brain itself, which can present in a variety of ways, from having dizziness to double vision, to having numbness or weakness on one side of the body. You can have damage to the nerves in the eyes, which can cause loss of vision, or you can have loss of color perception, where things look gray. And then you can have damage to the spinal cord, which can also present with that one-sided weakness or numbness, or it can be both sides of the body can be weak or numb, and you can have problems with controlling things like bowel or bladder, or problems with gait and balance.
So interesting, because if it's affecting the central nervous system and messages from the brain are being passed down those nerves into the muscular system of your body, it can go really anywhere. Because I have read some very peculiar symptoms, and sometimes the first symptom that people have are a flash sensation or a shock sensation in their face. Have you ever heard of that one?
So multiple sclerosis can present in a variety of different pain syndromes. What you're describing has a very particular name called trigeminal neuralgia. Basically, we have a nerve in our face called the trigeminal nerve, or the fifth cranial nerve, and it controls our sensation in our face. When this nerve is damaged, such as from the immune system attacking this nerve, it can cause this lanciating, sharp, electric-like pain in the face, typically on one side, around the eye, cheek, or jaw. It lasts a few seconds at a time and can be triggered by things like chewing or eating or brushing your teeth or touching the area. This can be extremely painful, but there are treatments to control this. That having been said, trigeminal neuralgia can present on its own without any MS, but MS can also present with trigeminal neuralgia being one of its symptoms.
Some other symptoms that I've read are clumsiness, weird prickly sensations, sluggish thinking, wonky vision, which you mentioned, but also that it can affect your cognitive function and emotions.
And thank you for bringing up that impact on cognition and emotions. So many times my patients with multiple sclerosis have problems with memory or thought processing speed. And they tell me that their coworkers don't understand because they don't see them using a cane or using a wheelchair, and there's an assumption that that's what MS looks like. But MS can have many different presentations, and sometimes it can affect our ability to think, problem solve, handle complex tasks, or learn new things effectively. It can cause cognitive slowing, and it can also cause people to feel sleepy during the daytime, or less alert, or more fatigued. And these can have a big impact on people's ability to work and function. This also has a lot of effective treatments, and there's a lot we can do to help improve people's quality of life, even with these symptoms.
You've mentioned that everyone presents in a different way. What are some of the ways that MS might present?
So many people have different patterns. And there are a few different main patterns of multiple sclerosis, or different types or categories of multiple sclerosis. There is the relapsing and remitting form. There is the primary progressive form. And there is the secondary progressive form of multiple sclerosis. So let's start with the relapsing remitting, which is the most common and affects about 85% of people who initially present with multiple sclerosis. So relapsing and remitting multiple sclerosis, it's when someone they're going along their way, they're completely normal, and then all of a sudden they have a flare or an exacerbation where they have a new change or new damage to their central nervous system. They have new symptoms such as change in vision or walking, and then they might make a full recovery, or they might make a partial or incomplete recovery. And after this, they kind of establish a new baseline. And then they might have another flare a year later, or 3 years later, or 6 months later. And that might then cause new deficits, such as maybe now they have problems controlling their bowel or bladder. And then they may make a full or partial recovery, and then they have established a new baseline. And that is your relapsing and remitting form. But then you also have your primary progressive. In primary progressive, this looks a little bit different. Instead of having sudden changes in your symptoms, you have just a slow, steady worsening of symptoms. For example, you might notice slowly over time, walking is worsening, balance is becoming more difficult, you might be walking more slowly, you might be having more pain. You can't put a particular date or time stamp on when this happened, but over the last year, you've been getting worse. And that's the progressive form. And then you have your secondary progressive form, where you start off in a relapsing remitting, where you have your plateaus and your drops. And then you transition to this form where you slowly progress and get worse over time, rather than just have those peaks, those plateaus and drops. And so different people present differently, of course, and people can have forms where they have infrequent flares. People can have forms where they have more frequent flares. And sometimes people who have one event or infrequent events might ask, do I need treatment? Do I need to be on anything? It's not really affecting me. And that's a really important thing to consider, because I think that we've had a new understanding of how multiple sclerosis works. And that it's not just these acute attacks, these sudden attacks of inflammation or damage to that the immune system is attacking the brain or spine, but there's also this underlying slow, smoldering inflammation or activity from the immune system that is causing this insidious damage that we don't see and that we don't perceive as clearly. And that this insidious smoldering inflammation might later lead us to go from the relapsing remitting form to that progressive form. And so getting treatment early can actually prevent us from progressing and be protective from transitioning from that relapsing remitting form to that secondary progressive form.
Interesting that you said that, because I read that in an old study, it's from 2009 in the Journal of Managed Care Medicine, that suggested that for every symptomatic MS attack, a person would have actually had maybe 10 attacks that were undetected or unrealized.
Yeah, I had a mentor who once explained MS in terms of an iceberg in the ocean. You kind of see the peak of the iceberg, but you don't see the amount of ice underneath the water. And so very often we see some of the deficits kind of surface, and we recognize some of the problems. But there is a bunch of damage underneath the surface that is not readily apparent. But as the disease progresses, those deficits become more and more noticeable. It's kind of like going from a deep end of the pool to a shallow end of a pool. And as the water becomes more shallow, you begin to see more and more of that iceberg emerge.
You described a case or a presentation where the patient would have intermittent episodes, and then they would perhaps change. What's that, the progressive primary presentation?
So with the primary progressive, it's you typically just slowly worsen over time rather than having discrete time-specific deficits.
Can a person get better and instead of getting worse? Why would a patient have an experience or an episode and then not have another one again? Is it possible that a person can have damaged nerve endings and that they heal so that they don't get worse?
So after an MS exacerbation or flare, people can have some recovery. And typically people will recover the most within the first 3 to 6 months of the event or the injury. But as time progresses, it becomes less likely that they will recover. Now, when myelin is damaged, it doesn't typically repair, but we can compensate very often. And very often doing things like physical therapy or occupational therapy can help people regain some of their functionality. Right now, the treatment options that we have available do not repair damage that was done, but they are very important because they prevent further damage from happening and allow people to maintain their functionality and maintain the life that they're used to.
What happens if they don't get medical treatment? I mean, before the 90s, I guess, the early 90s, even at that, there were no medication treatments for MS. And now we have a small collection, I suppose, of them.
Yeah, the first treatment came on the market in 1993. And before that, there were no treatment options. And now we have over 23 medications available on the market. And so it's been a true revolution, and the medications have really changed in their efficacy, and we have a variety of ways to give and deliver these medications to personalize them for our patients. I remember that people used to say they didn't want to work with MS because there was nothing you can do. But the truth is there's always something more you can do for someone with MS, and there is so much that we have the potential to do with the new treatments. The treatments have really revolutionized things. And before, I can see the difference between patients who were diagnosed in the 80s to today, and they have a completely different outlook on their prognosis. And so one thing I'd like to emphasize is that multiple sclerosis now is a very hopeful disorder, that there is so much that we can do to help our patients and so much we can do to preserve people's functionalities and help them maintain their lives.
How have you seen medications change the quality of life for a patient, for example? Can you share some of those experiences with us?
Oh, sure. So I remember I had a patient she was diagnosed with MS, and she was quite frightened of this diagnosis.
Sure.
She was afraid to confront this disease and to deal with it. So for a while, she wasn't going to her doctor appointments and taking medication.
How old was she?
She was in her 30s, and she was working. She's a mother. And we would try to get her started on medication, and she would say, I don't need anything. And I remember we would get a call every 3-6 months. She would have a new MS flare exacerbation. She would tell me she was having new pains, new difficulty walking, and initially she was very resistant to having treatment. But once we got her on a high efficacy medication, these events stopped occurring. She stopped having new exacerbations, new deficits. And I remember she told me, I wish I'd started earlier. And so that can be a big challenge because it is, people can be intimidated by the diagnosis. And it can be natural for people to try and just normalize their life, try to avoid dealing with the diagnosis. But the truth is, naming it, recognizing it, and addressing it can really allow you to own the disease, take control of it, and so that you are the one in charge and that you're being able to manage it so that you can continue living your life, continue doing the things you enjoy, and prevent yourself from being interrupted from the things that are important to you. And so having those options to have treatment can be a big deal. And it used to be that people would have to inject themselves, which can be difficult. But there are a lot of options now that are including oral medications, infusion medications, so that we can really personalize it so that it doesn't interrupt your life and that it meets the way you need to work around your family and your work, and so that we can kind of personalize it.
Are the medications treating the symptoms, or are they designed to actually stop the immune system from attacking the myelin?
These medications are all preventative. So their job is to prevent the immune system from attacking the brains and spine and the nerves and the eyes. So they typically don't treat these symptoms. But some patients have told me that they feel better, less fatigued, or less pain on it, especially with some of the medications. And there's a thought that there might be some smoldering underlying inflammation that is constantly present, and that by addressing this inflammation, it might make people have a little bit less fatigue or brain fog, or maybe improve some of their walking. That, however, is what is a little bit of icing on the cake. The main goal is to prevent worsening. There are treatments, however, to manage the symptoms of MS. And there are quite a lot of different symptoms, and there is an arsenal of medications that we can really utilize to help reduce some of the burden of multiple sclerosis, from managing the fatigue to managing the pain or managing spasms, so that patients can have more normalcy in their life.
Are there side effects to these medications?
Every medication, unfortunately, comes with its own side effects. But the role of a physician is to partner with our patients to help them understand the benefits and also the side effects and possible risks, and to find which medications work best for them to meet their goals.
What are some of the side effects? Let's talk about that. What can we prepare people for?
So one of the biggest issues is pain. Patients can have things like burning pain or tingling or pins and needle sensation. Some medications that help treat that can help really reduce that pain, but can cause things like being sleepy or more tired. They can cause things like weight gain or sometimes some swelling in the legs. There are medications that can help with things like the spasms or cramping or muscle discomfort, but these can also sometimes cause some sleepiness as well. And if you use too high doses, sometimes it can cause a little bit of weakness. There are medications that can help with feeling that daytime sleepiness or being very fatigued, but they can also cause some issues like feeling like your heart is beating a little fast or having a little more anxiety or risk of headaches. There are medications that can help people walk more quickly and to help with their thought processing speed, but sometimes this might increase someone's risk of something like a urinary tract infection or low back pain. So there is always that cost and benefit that we weigh and measure when trying to address how to best treat patients' pain and discomfort and symptoms. But what I like to emphasize is there is a lot we can do, and that as a doctor, one of my great joys is working with patients to find what works for them.
What else can patients do when they're symptomatic of MS? Is there diet? Is there therapy, perhaps?
So physical therapy can be very beneficial and can help a lot of people. And many of my patients improve and make great strides with physical therapy. One thing I also highly recommend is being physically active. With multiple sclerosis, being physically active, even if it's 15 minutes 3 times a week, or doing something brief and small, will help with things like your muscle strength, or helping with fatigue and tiredness. And so exercise, of course, is a great benefit. One thing I recommend for my patients is swimming. Sometimes people can feel weak or they can have pain, and swimming helps reduce that gravity so that it becomes much easier to exercise. And some of my patients do aqua therapy, which they find is very helpful as well.
Oh, actually, there's an aqua therapy program through MedStar Good Samaritan.
Yes, I had some patients put in that program, and they've found a lot of benefit from it.
Oh, wonderful. Wonderful to know. So it brings us to why. How do people get this? Is there an inherited factor? Is there an environmental factor? How are people getting MS?
So that is the million-dollar question. And there is no absolute answer. And that's partially because I think this is a very complicated disorder, which is caused by many different factors contributing. So there is some thought that there is a genetic component. Over 200 genes have been identified as having possible relationship to multiple sclerosis, but none has been absolutely identified as if you have this gene, you will have MS. And so it's likely a factor of multiple genes interacting with each other. Sometimes patients come to me and they're very concerned because their family member has MS, and they worry if their family member has MS, they most likely have MS. And I would like to really reassure people that although there is a thought that there's a genetic component, that's not the whole picture, and genetics isn't everything. In fact, when we look at genetically identical twins, 35% of patients whose twin has MS will also have MS. So even if you're genetically identical, there's a 65% chance that you won't have MS. And when we look at siblings and parents and children, there's a maybe 2%, 3% risk of having MS if you have a first-degree relative with MS. And so again, very small genetic risks. There's also some thought that some infections might cause one to be more likely to develop MS. There's a big theory out now that Epstein-Barr virus, which causes mono, might be contributing to MS, and that exposure to this virus might trigger people to have MS. That having been said, this is very hard to prove because over 90% of the population has been exposed to Epstein-Barr virus at some point. So even with that, it's not enough to cause a MS alone. Otherwise, 90% of the world would have MS.
The Epstein-Barr virus that you just mentioned, also known as EBV, is a herpes virus.
I don't say
It belongs to a large family of viruses called herpes virus. Some data has suggested that other members of the herpes virus family might influence MS risk, leading scientists to examine the connection between MS and the infection with human herpes virus.
So it is possible, and we've looked at several different viruses that might be increasing one's risk for developing multiple sclerosis. The viral theory is a little hard to prove, and the evidence supporting herpes virus in particular is not well established. So I don't think we can say that herpes virus causes MS, but again, this is very hard to identify, so It's unfortunately something that's not fully elucidated right now.
Well, the most recent news reports that I found on what might lend itself to be a cause for MS is a microbe found in sewage, marine sediment, soil, and the GI tracts of pets and farm animals called, and this is from the Journal of Clinical Investigations, but it's called C. perfringens. Am I saying that right? It's a bacteria that might be something that they can develop a vaccine for. Is that on the horizon, do you think?
So I haven't heard any literature about starting a vaccine for C. perfringens.
But you've heard of the bacteria and its relation to MS?
So I haven't heard of its relation to MS in particular, but there are some viruses or bacteria that have been more favored than others. But of all those researched, the most popular is EBV.
Who's a typical patient? Who gets MS?
In medical school, we always used to be presented with cases. And we used to say there was these classic cases that you would know if you got presented with this type of case, the answer would be this disease. And it always used to be, if you have a young white female, then the case is MS. But I think that is really doing a disservice and not fully understanding how prevalent the disease is and the different types of people that can be affected. And I think as we get more data, we're understanding that different groups are being more affected than we originally recognized. So most often it affects young people. The average age of onset is in the 30s. It does affect women more than men, but of course men can get it. And we've come to recognize that it is more common in Caucasians, but we're recognizing more and more that people of African descent are also likely to have MS as well. And we're recognizing that diversity of this disease more. The classic teaching is that it is most often a disease of young adults. However, as we do more and more MRI imaging, we're finding in older adults as well. And so we're coming to recognize a new population that also can have MS. And so for me, whenever I see a patient, I always keep an open mind. I never say, this type of patient has this disease, this type of patient has that disease. I think you always have to look at each individual and really listen to their story and take in all the information and then understand there is no one classic individual that is prone to have MS versus another.
How do most people find out that they have MS? How is it diagnosed?
Very often, individuals have a story where they had a symptom. It wasn't really clear what it was. They went to the emergency room or they went to the doctor. It went away. They forgot about it. Then it happened again. Maybe again, no one quite figured it out. And then they had another event, and finally they made it to a neurologist, had the MRI, and it was diagnosed. And so it can be a process where, because this is a disease that presents in so many different ways, where there is no absolute or classic presentation. And so it can be challenging to make that diagnosis, and sometimes it can be a journey where you are seeing more than one doctor, or where you're having more than one hospital visit before someone discovers the actual diagnosis.
Which is how? How does that happen?
There are a couple different ways that we diagnose multiple sclerosis. One of the most important tools that we have is using the MRI. And we look at the pictures of the brain and also the spinal cord. In addition to this, for some patients, it can be helpful to look at what's called cerebral spinal fluid. Cerebral spinal fluid is fluid that bathes the brain and the spinal cord. And we pull out a little bit of this fluid using a long needle that's placed in the spine. And looking at some of the proteins in this fluid can help us identify multiple sclerosis.
Is that under sedation? Is the patient asleep for that?
So it sounds more scary than it actually is.
Sounds very scary.
What I will say is a lot of people do quite well with this. Very often what we do is the patient is typically awake, but we numb the area with some lidocaine, and then we draw out the fluid with a needle. And most people tolerate this very well. Some patients have told me that it was not as bad as they thought it was going to be. But of course, if we can avoid doing this, we do.
So what are you looking for on the MRI? Once you receive the images back, how long does it take once the MRI is conducted? Does the patient get an answer? So
it depends on what we see on the MRI. Some cases are more straightforward than others. But what I'm looking for in the MRI is these areas of spots or dots, which indicate areas of damage. And I'm looking for a very particular pattern of where it's located and what the shape and size is. And I'm also looking at whether two different things. We use the term dissemination in time and dissemination in space. What this means is I need to see at least two areas of damage. I need to see them in two different locations that are classic for MS. And also I need to see that these areas of damage occurred at different times. They didn't occur all at once. And there are different ways to figure out if there is a different time course for some of these different areas. We give patients a dye called contrast. And when someone has a new area of damage within the last 30 days, the contrast allows these spots and dots to light up. And if I see that there are some areas that light up and some that don't, that tells me that there is that dissemination time, that these different areas of damage occurred at different periods. And that can be what we use to make the diagnosis of MS. Now, in addition to using the brain imaging and sometimes that spinal cord fluid, we can also do a couple of blood tests. And although there's no definitive blood test for MS currently, the blood tests can be used to rule out other things that might look like MS but are something else.
Such as what?
So there are a variety of other diseases that can mimic MS. And these can be things like vitamin deficiencies, like having low vitamin B12. It can be things like having Lyme disease or HIV or syphilis, so those type of infections. Sometimes some rheumatological disorders can also look like MS. And also we have other autoimmune diseases where, again, the immune system is attacking the brain and spine that look like MS but something else. For example, neuromyelitis optica spectrum disorder or MOGAD disorder, which are a mouthful, but are different disorders that we treat differently. And it's important to keep an open mind to look out for those other causes so that we don't miss them.
Describe what your role in the process is as a neurologist. Patient comes to see you. Do they already have a diagnosis of MS?
So some of my patients come to me already with a diagnosis of MS. Maybe they were told by another neurologist, or maybe they were told when they went to the hospital. And some of my patients are coming to me because they don't know and they're looking for an answer. So the first step for me is to listen to the patient, to hear their story, to hear how things presented, what was their course, what symptoms did they experience, what was the timing of those experiences. And a lot can be gleaned from the story. The next step is the actual exam. We are looking for signs of MS. Sometimes this can be how the pupils constrict and dilate when they're given light. It can be how they're doing when they're walking and how is their balance. There are a variety of ways to help assess through the exam if they have symptoms consistent with multiple sclerosis. After that, typically I will do the MRI. And depending on the MRI, I may or may not request that spinal fluid. And at the same time, I'm starting with the blood work to rule out any other causes of multiple sclerosis. Sometimes there can be some other tests as well, like doing what's called an OCT, which is an eye exam, that also can be used to help parse out if this is multiple sclerosis or not.
What would you be looking for in an eye exam?
Multiple sclerosis can affect our eyes as well, and we can look at something called the retinal nerve fiber layers, which are these fibers at the back of the eye. And we find that with multiple sclerosis, when someone's had it damage to the eye for a while, those fiber layers get very thin. And so we look and measure those fiber layers to see how thick or thin they are, because that can also be suggestive of whether or not someone has multiple sclerosis.
So it's a combination of different tests and a process, and sounds a little complicated to get that diagnosis, but I'm sure that you want to get it right so that you can use the right medications, because it could be several other things as you've already described.
It is a process to figure it out, but it's something that I partner with my patients and we work together, come to that final diagnosis to give our patients answers.
With the difficulties involved and there's no cure, does that ever get discouraging? Why would you go into neurology, actually?
Well, what I'll say is I've actually found that multiple sclerosis is an incredibly hopeful field, and that's one of the things I love about it. Is I remember one of my mentors saying, the person that comes to you the first day on their first clinic visit, that's to be the person who's in front of you in 20 years. And that is my goal, that they stay the same physically, to try and maintain their functionality, to maintain their abilities, to allow them to continue to do what they love. I've had patients who they were filmmakers and they continue to be filmmakers. I've had patients who were CFOs of banks and they continue to be a CFO of a bank. I have people who are mothers and they continue to build and grow their family. They continue to make it to soccer practice and they continue to make the best snacks. I have a patient who she had from her multiple sclerosis foot drop. And she had difficulty walking, but she loved hiking. So we got her a device called a BioNest that helps lift her foot. And now she started a walking club, or climbing club for MS patients so that they can continue to walk and they don't let their disability get in the way. And so that's what I love about MS.
That is very encouraging, very encouraging. Was there something while you were in medical school that compelled you to go in that direction? Or did you discover that even before medical school that you were really attracted to the field?
I think the thing that most attracted me to the field was my patients. I think that, seeing how you could take something that is scary, like a diagnosis of MS, and show someone how it is hopeful and how there is so much you can do and how they're going to keep trucking along. I think that was an amazing experience for me when I worked with my patients, and it was something that I knew that it would be a privilege to continue to be involved with.
And how do you keep them hopeful?
I tell my patients that we have a lot of options, that we can tailor things to what they need, and that we can try to take control of this disease together.
Is there anything else that you think patients should know or that listeners should know about multiple sclerosis?
One thing that a lot of my patients tell me is that people don't understand. It's hard to make their families understand. It's hard to make their coworkers understand. And sometimes that can be isolating. And sometimes patients can feel depression. They can feel anxiety from this. And those feelings are normal. One thing I tell my patients is it's important to continue to communicate. Communicating to your family what's going on with you, communicating to your workplace what you need, because there are accommodations that can be made, there can be resources that are available, and it's okay to ask for help as well if someone's feeling low, sad, depressed, or anxious. There's a lot of help and resources available as well, and that it's okay to get help. Sometimes my patients think, of course, it's okay to get help for things like their MS, getting medications to control the disease, but then they don't think it's okay to get help for things like the emotional aspects. And that is just as real a part of the disease as anything else. It goes back to that metaphor of that iceberg under the ocean, where some people might see some of it, but not everybody has a cane or a walker. Some of multiple sclerosis is pain, which isn't obvious always. Some of it is feeling that tiredness. Some of it is feeling that brain fog. And people might have a difficult time explaining to others that that is part of their course and that is just as real and valid as someone who needs to use a walker or a cane to get about.
Well, I'm glad that you continued with that training and that you are doing what you do.
Thank you.
Thank you for all that you do.
Well, thank you. That's very kind.
We've been talking with Dr. Tamar Harel at MedStar Union Memorial Hospital in Baltimore. Thank you for sharing your expertise with us today here on MedStar Health DocTalk. For more information or an appointment with Dr. Harel, call 410-554-2286 or visit medstarhealth.org/Harel, Harel.